Hello, my name's Andrew Tatham. I'm a consultant glaucoma specialist in Edinburgh, Scotland. The title of my presentation is IOP Monitoring Using an Intraocular Sensor Before and After Glaucoma Surgery. Here are my financial disclosures. Raised IOP is a major risk factor for glaucoma, with several randomized control trials showing that IOP reduction can help slow visual field loss. However, conventional methods of IOP assessment have limitations. IOP fluctuates, which may make it difficult to identify true peak IOP and therapeutic effect. IOP is affected by biomechanical properties of the cornea, and of course, it's also a surrogate for what matters most to patients: vision. The use of sensors to monitor health forms an important component of the management of several chronic diseases, including diabetes and systemic hypertension, and there are now devices available for home perimetry and home tonometry. The EYEMATE IO is a sensor that can be placed into the ciliary sulcus at the time of cataract surgery. It's encapsulated in silicone rubber with 4 haptics to ensure stability. A handheld reader can be placed in front of the eye to obtain IOP measurements. The reader can store up to 3,000 measurements and also upload measurements to the cloud for remote access. The recent Argos 2 study concluded that the device was successfully implanted into 22 patients with few surgical complications. The aim of this presentation is to describe the first case of glaucoma surgery in a patient who had previously received an EYEMATE implant. The case involves a 75-year-old male with primary open-angle glaucoma, uncontrolled on a maximal medical treatment. His pressure preoperatively was 25. He had a dense cataract with vision of only hand movements. It was decided to perform a left cataract extraction combined with the EYEMATE procedure. On post-operative day 1, vision had improved to 20/30, but the pressure remained high at 90 mm of mercury using Goldman tonometry. This chart shows IOP measurements from the EYEMATE over a period of 8 months. The patient was able to obtain over 1,000 measurements during this period. Unfortunately, his pressure remained high. He was started on acetazolamide here at time point A. There was a reduction in pressure, but he was unable to tolerate acetazolamide for long, and so he underwent a trabeculectomy. There was an aggressive wound healing response, which despite suture removal and 3 needling procedures was unsuccessful. The increase and reduction in IOP with each intervention was clearly captured by the EYEMATE. Due to sustained high intraocular pressure, the patient underwent a glaucoma drainage implant procedure with a pool glaucoma implant. This successfully lowered his intraocular pressure, shown here at time point B. The pressure began to rise again over the next few weeks, but the intraluminal stent suture was removed, and this has resulted in a sustained reduction in IOP over several months, with a further 947 IOP readings. The patient showed sustained interest in self-monitoring IOP, with this chart showing the number of measurements taken per month during the follow-up period. So in conclusion, the IOP sensor enabled remote and frequent monitoring in the post-operative period. The ability to monitor the patient remotely allowed for increases in IOP to be identified and appropriate action taken. And lastly, remote monitoring offers the potential to reduce the frequency of face-to-face visits. These are the references for the case. I'd like to thank you very much for listening to the presentation.